Thank you very much. It's an honor for me to be here to share with you about issues in HIV-positive children. I'd like to share with you that children with HIV come in many sizes. They come with many different issues and they need our individualized attention and care. These are some of the children who are seen in our clinic: a 3-month-old healthy girl who has positive HIV DNA PCR, a 5-year-old healthy boy who's just diagnosed with HIV because his mother passed away from the disease, or a 12-year-old who is failing treatment because of poor adherence. I'd like to go over some of the management issues during my talk, and we'll come back to hear about these children at the end of the talk. So in the next 20 minutes, I'd like to share with you the pediatric HIV situation in our region, talk about advances in management, particularly results from randomized study on when to start and what to start treatment with, long-term effects of HIV and its therapy, and also talk about a very important issue on how we support children to grow up, to live and cope with HIV. I will end my talk with a 3-minute movie clip that is, the topic is Who Am I? Why am I here? And these are voices of Thai children with HIV. So I hope that this will be useful information in helping you with your work, as well as understanding the issues surrounding pediatric HIV. So in Asia, we have 160,000 children living with HIV. And despite many effective ways to stop the transmission from mother-to-child transmission, we have 22,000 new infections each year. The pediatric ART coverage is about 44%, and this does not include children under 2 years who now fit the initiation criteria. The TAPOT regional cohort is run by the Treat Asia network, and it includes 4,000 children in 16 sites from 6 countries, and it showed that over half of the children in the region are starting treatment after they develop severe HIV, and unfortunately half have lost at least one parent, and this greatly affects their lives and their outcome. And 24% lost to follow-up rate at 5 years, so there is definitely room for improvement. So when to start treatment, it is important to understand that children have a bimodal HIV disease progression, meaning that very early on, they have a much faster disease progression to AIDS and death if they're younger than 2 years. After that, they have a slower disease progression rate. So the WHO guidelines recommend that all children under age 2 years should start on treatment immediately, regardless of their CD4 count. And this requires, of course, knowing who is HIV exposed and access to HIV PCR diagnosis. So these recommendations are based on evidence from the CHIR study that was a randomized study of when to start treatment in young children. How about older children? The WHO guidelines recommend, of course, treating children who have advanced or severe HIV disease, but children who are well, have mild symptoms or asymptomatic, there are CD4 criteria with higher threshold for younger children, lower threshold for older children. Over 5, they follow the adult recommendation. Now you can see that these are strong recommendations, but they are based on very low or moderate quality evidence. This is because up to now there were no randomized studies. Our group, HIFNet, with 8 other sites in Cambodia and Thailand, have just finished a study looking at when to start treatment in older children, and the results were announced at the International AIDS Society in Rome. So here we enrolled children 1 to 12, but almost all were over 2 years, with CD4 in the moderate immune suppression range, and they did not have severe HIV symptoms. You can see here the average age was 6.5 years. One group started ART immediately, the other group deferred until CD4 less than 15%. And they got CD4 monitoring every 3 months. And during the 3 years, 46% reached that CD4 criteria and started treatment. And because of frequent CD4 monitoring, you can see here that children started ART just slightly below 15%. CD4 at start was 14%, which translated to CD4 count of about 600 in children younger than 5 and about 300 in children older than 5. And the important lesson here is that after 3 years in both arms, the AIDS-free survival approached 100%, meaning that whether they were treated immediately or deferred, the number of children who had AIDS or death was extremely low. So what does predict result tell us? It tells us that we can decide individually what is the best thing for that family, recognizing that treating children is not easy. It requires a committed caregiver. The pediatric formulation is limited. And so in children who are healthy and they're older, we could use judgment to defer ART until CD4 less than 15% as an option for treatment strategy if close CD4 monitoring can be done. So what ART regimen to start with in children? This is the PENPAC-1 study that was done in the US and Europe in older children, and these are children who were not exposed to single-dose nevirapine. And they saw that NNRTI or PI first-line treatment had equal efficacy. And here in the graph, in the y-axis, are the proportion of children who are still on first-line treatment, and the x-axis showing the time out to after 5 years. And you can see clearly that there's no difference. And the PI and NNRTI regimens are listed here, and the average age of the children was 6.5 years. How about younger children? The P1060 cohorts 1 and 2 show a contrast finding in that nevirapine had higher virologic failure rate than lopinavir treatment, regardless of single-dose nevirapine exposure. And in the y-axis here is the percentage of children with virologic failure. And the x-axis, you can see two groups of children. One group were exposed to single-dose nevirapine. The other group were not exposed to single-dose nevirapine. And in each group, they looked at nevirapine in blue compared to lopinavir in red. And immediately you can see that nevirapine had a higher virologic failure rate in both groups. And this is likely that young children under 2 have very high viral load. And lopinavir has a higher genetic barrier to resistance that may account for this finding. So in the WHO guidelines, there's recommendation on using lopinavir in children under 2 that are exposed to single-dose nevirapine. But the P1060 data suggests that in children who are not exposed to single-dose nevirapine, lopinavir may be needed as well. So there's limitation to this because supply of liquid lopinavir is not easy. It requires refrigeration, short expiry date, and there's no suitable pediatric tablet formulation for infants at the moment. So if we start all young children on lopinavir, do they need to be on it lifelong? And the NEVEREST study randomized children to staying on lopinavir versus switching to nevirapine. And they saw that some children may be able to switch, provided that they have no NNRTI mutation before they start ART, and they have virologic suppression on lopinavir. So this brings up the question that then you need access to genotyping and also access to viral load in order to do this. So how about complications of HIV and its therapy? Pediatric treatment failure is what we all worry about. And in the Thai National Guideline, the number of children on second line has increased from 4% in 2005 to 20% in 2010, and this is likely due to routine viral load monitoring, capturing children earlier. The TAPOD regional cohort showed that 14% of children in our region are